Hello, and welcome to Global Scalpels, a podcast dedicated to the 5 billion people worldwide who lack access to safe and affordable surgery.
I'm Rihanna.
And I'm Taylor.
And together we're Global Scalpels.
Our guest today is a trauma surgeon from Syria who led the surgical training and clinical relief initiatives during the Syrian civil war that started in 2011. He holds both a master's degree in general surgery and a doctorate of medicine from Aleppo University, where he is also a current surgeon and former faculty member. Since the start of the war, he has dedicated his life to providing trauma care to all in need, including training junior physicians to do the same. In addition, he was the director of research for the Union of Medical Care and Relief Organizations, which was the focal point for most NGOs operating inside Syria. In this role, he led a nationwide survey of hospitals to identify their capacity to provide trauma care. This study was published in JAMA Surgery this June. Further, he took part in the Harvard Humanitarian Initiative, HHI, through the Scholars at Risk program and is currently working on building health information systems in northwest Syria. We're very grateful to have him on the show today. So with that, we're happy to welcome Dr. Mahmoud Hariri.
Hariri in English, it means silky, by the way.
Silky.
I like that.
I love it.
Good start. Thank you so much. Thank you for hosting me. I'm very happy to. Okay.
We're very glad to have you, Dr. Silky.
Thank you so much. By the way, many of my friends used to call me Dr. Silky, especially in UK. I've been in UK, by the way. I studied for a short time over there. They used to call me, "How are you, Mr. Silky?"
Okay. That's fantastic. I love it.
Thank you so much. I'd like to start back a bit, step behind, just to tell about the starting of the demonstration in Syria. I'm back from United Kingdom in 2005 and started my scholar in Aleppo University School of Medicine. In 2011, demonstration started in Syria. And I found myself, I have to be part of this, we call it as a revolution against dictatorship in our country. At the beginning, we chose a small group of doctors or medical students. By the way, this is the reason for my name here, Abdulaziz Adel. This is my not my real name. This is one of the, maybe the third or fourth nickname I use it during this demonstration period. You know, we have a concern about our family on the other side, as far as you could be kidnapped or killed at any time. So we were 7 persons. We called our group as Nur al-Hayat, the light of life. It's a small group, 5 medical students and 2 doctors, me and other one. Those doctors, those medical students were my students, and they don't know they are dealing with whom, because I was hidden. I would just talk to them on phone and not seeing them. One of them, by the way, now in Johns Hopkins is doing public health training for a couple of years. So those guys, when they have any demonstration, they have to join this demonstration, hidden around, carrying bags. These bags contain some medical first aid. And when there any shooting or any injury, they used to take this injury aside and take him home, some homes, we choose some homes, and do the first aid. If there is anything needed surgery, they will take him somewhere, and maybe we can do this surgery in some hospitals inside the regime area, it was very difficult and dangerous. So then when you call someone, they used to call me on my maybe fake numbers of maybe 4 or 5 numbers, and changing my phone numbers maybe every other weeks. And they used to call me. My first name was at that day John White. So Dr. White, we have this patient, and this patient now in the hospital, please join to the hospital. Of course, when I have to go to the hospital, nobody should be there from my student, because they must not know who is this hidden guy. So doing this surgery, maybe for 1-2 hours, and immediately take the patient out of the hospital. Otherwise, maybe the police coming and take this patient and kidnap him. So this was the situation until one of the most important day in our life when two of our guys, those five guys, medical student, has been kidnapped, arrested, and in a week we found their bodies burned and killed and tortured severely. I've maybe horrible images for this. It was very prominent day, very important day in my life. Honestly, we feel scared, afraid. We are facing, I don't know what we call it. It's a type of very horror issue. After this day, I changed my nickname to Abdulaziz, which is now current nickname I was using in Syria. Afterward, the city of Aleppo divided into two pieces, two parts. This is in 2013 almost, by the end of 2012, sorry, to 2013. Starting from this time, all of our life changed. Two also of our guys again kidnapped and tortured, but fortunately we tried to pay for some money to bribe someone to release them. And fortunately, after 2 weeks, those two guys released. One of them now, as I said, he's in the United States, and the other guy is now finishes training in medical school here in Turkey. This is just the beginning, just to know what sort of dictatorship regime we are dealing with. In the eastern part of Aleppo, we started to build the hospitals, to use maybe already built hospitals as a field hospital. But as you know, it's the main target for this regime was hospitals. So we use only the underground in the part of this hospital if there is underground. Otherwise, try to find somewhere else underground, a big hole maybe, and try to make it as a makeshift hospital to treat our patient. Normally, any patient after doing any type of surgery, mostly in maximum couple of days maybe, have to leave the hospital. Otherwise, he will be under risk of being attacked or killed by another bombs or could be by any time by any type of weapon. So normally the staying, let me say, the average lengths of stay in our hospital no more than 2 days. And up till now, by the way, still this is the issue. So we have to discharge our patient as fast as possible, as rapid as possible. We used to have some houses outside, furniture in some hospital beds, and there's some nurse and doctor visits them depending on his time. And this is separate from a hospital. It is a house, it's far from the hospital, and this is easier for us to treat our patient. By the way, if you'd like to go to open a hospital in a village, for example, and we tried many times, we need to make a hospital in this village, for example. The people in this village usually demonstrate against us. We don't need more hospital in our area, otherwise we'll be a target. We will be a target. If you put a hospital in my street, in my area, in my village, it means that this area will be a target for this bloody regime. This is the situation. So think about this. Think how it's risky for those doctors who are just treating patients, how they're living in this situation. This, by the way, in 2019 only, the number of hospitals, there is a report, more than 114 health facility has been targeted, almost, I'm not sure from the number, has been targeted only in 2019. Many hospitals totally collapsed. Up till now, we lost almost 900 health personnel has been killed or kidnapped or arrested. The meaning of arrested or kidnapped, almost 100%, it means he will never be back. He will be killed by any way. In a weeks, in a month, he will be tortured, especially if he is a doctor or treating a patient. There is a long, long story about this. There is a lot of people has been killed. One of them is my relative, is a pharmacist and is being kidnapped. And in 6 weeks, oh sorry, in a 6 months, they told us, come and get his ID, only his ID. The body never ever that your relative has been killed or he died from cardiac attack. Cardiac attack, 25 years old guy. Anyway, we have to believe it
Yeah. Yeah.
and considered as real, unfortunately. This is just a background about what's happened.
That sounds horrible. And I think, even in the best of times, it can be difficult to set up a hospital. But how have you managed to create these hospitals where you've got so much resistance from the people living there, as well as a lack of infrastructure and a lack of workforce?
Well, this is one of the maybe nightmares when I'd like to start to establish a hospital. In 2014, for example, we had one of biggest hospital in Aleppo, which is targeted. It was, I think, in June. The whole building, which is 6 stories, has been collapsed, totally collapsed. And at that day, we thought that we have to look to another hospital in the area because the number of hospital is not enough. By the way, when we are talking about hospital, do not imagine it's 100 of beds or something fancy like somewhere in the world. I've been in Boston, for example. I saw the Boston hospital, which is maybe, I don't know, 2,000, 3,000 beds. In Syria, when we say this is a hospital, it means 10 beds, 12 beds, 20 beds. The maximum number of beds is 100. There is only 2 or 3 hospitals currently in Syria with 100 of beds only. So when we have 60 hospitals, let me say, it doesn't mean that we have a lot of beds. It means maybe we have 400, 600 of beds, that's all. So we would like to start another makeshift hospital after targeting this hospital. And we found a building and we try to furnish the underground, and which is underground, 2 stories underground. It doesn't mean the first one, the second one underground. And try to fortify this hospital by any means. We built 2 stories above it just to keep it empty for nothing, just for protecting those staff in this underground. And we put some sort of sands, plastic tires, which is full with sands, surrounding the hospital and on the top, on the roof of this hospital on 2 levels. So we discussed with some of our colleagues who are engineers and just to tell us about how to absorb the barrel bomb or any missile which is targeting and unable to penetrate at least the main roof where is the staff. We can change this hospital maybe in a days. If we have the first attack, we can evacuate our staff or our doctors if after the first attack, okay, but at least try to absorb the first attack, not injure those innocent people. We have a lot of stories in different areas in Syria. We lost one of our orthopedic surgeon. By the way, he died just because he'd like to keep on his patient. This hospital has been targeted in a chemical weapon, in chlorine, and the doctor, he was doing surgery. Dr. Abdullah, he was doing orthopedic surgery for a patient. He said, if I kept my patient on the theater, he was in the theater doing his surgery, this patient will die. But unfortunately, we lost our colleague during doing this surgery. Regime used many type of weapon. When he found this fortified hospital, okay, I can throw chemical weapon, which is spread easily and cannot fortify yourself from a stream of chemical weapon, which is, will kill you, by the way. And we lost many of our friends like this. But anyway, we try to do our best to fortify such hospital to be able to survive and help those people.
It's just incredible to think that you're you're trying to bury your hospitals from missiles being attacked. As if being a doctor isn't stressful enough of trying to treat your patients, then now you're worried for your life because you never know what's going to come through. Perhaps some of our listeners haven't really learned very much about the Syrian conflict and the war before. Do you think you could just provide a brief overview of kind of what the origins of the conflicts are and why the war even started?
Well, uh, it's a long story back to 50 years when the first dictator, the father of this man, came to power. It's a matter of freedom, democracy, dictatorship. This is what's happened in our country. The first revolution, not now. The first revolution started in 1987, the first revolution against this dictator. So it's just a continuation of the dictator. It's just a continuation of the revolution against dictatorship. So the unfortunate in this issue that is the neglecting of the international community for the rights of the Syrians in our country. And unfortunately, this neglection is still up till date, even in COVID-19 problem, as I told you at the beginning. The COVID-19, even it's part of the neglection of our country and neglection of our people inside Syria. Those innocent people, the only crime they did, they asking for their freedom, for democracy, for human rights. And 2 days ago, by the way, there is a memory for in 2014 when a village, when a big murder happened in a village. Maybe I will send you some links about this very horror issue when 1,200 innocent civilians has been slaughtered, not killed, slaughtered until death. Not only killed by a weapon, most of them may be kids, women, and innocent people. In one family, there is more than 17 member of this family, starting from 3 months up to 70 years, has been slaughtered at home in front of each other. They ask one mother, how many kids you have? She said, I have 4. They said, which one we would like to start? You need us to start with the slaughtering, the junior or the senior, just to know the horrorship of those people. So our problem in Syria, it's not civil war. It's not the people who are conflict with each other. It's a matter of people need their democracy and freedom, and forget about any other things you can see on the media, because most of this information is fake. Just go deeply and see and analyze what's happening in the country in reality.
So it sounds like it's been quite a politically complex situation for a number of decades now. And it just sounds incredibly difficult for yourself and for your colleagues to be working in that environment. Despite everything that you see around you, you're still continuing to work to provide trauma care for your patients and working with your colleagues to make sure there are hospitals for people with problems. What drives you to continue to be a trauma surgeon in spite of all this hardship around you?
Well, I've been asked this question maybe many times. Why you are here? Why you are keep going? Why you are keep continuing? And we feel that this is part of our duty. I don't like to say that those people or any of us are hero. We are not hero. We are very simple people feeling about this person who is killed, who is injured, is part of our family, is part of, is my, it's just like my brother. I cannot feel that any of those, if his little boy is my son, if is my sister, my brother, my mother, I have to do something for them. I will never forget a little boy, and I used to talk a lot about him, this little boy, because it's affect me. He is injured in subclavian artery, and by the way, I've told this, say this many times. I'm not a vascular surgeon, but I used to be a vascular surgeon in this situation because I have to do something for a patient in case of there is no vascular surgeon in our hospitals. So I did surgery for this little boy. He's 10 years old. And when he went out of the hospital in 2 days, by the way, he had paralysis in brachial plexus, and his left arm was almost paralysis. But he was happy that he survived from death. And in the day of discharge, I just enter his room and try to mitigate and say, okay, how are you, little boy? You are fine, and now you go discharge. He tried to hug me by his paralyzed arm and said, oh, doctor, I love you. Honestly, I was crying at this day. I was crying. I cried. I went out of the hospital. There is a little tree, and put my head and cried honestly for half an hour. I think this is much better than even Nobel Prize. Honestly, it's much better for me than a big prize in the world. It's a prize of humanity, a prize of a person, a little boy who finds someone to treat him. In Aleppo, the population at that time is around 500,000. We were only 20 doctors, 22 doctors treating 500,000 population. Of course, this is including medical student. Those colleagues, which I told you about them, the medical student, they continue working with us as a surgeon. They were doing surgery. Medical student in the 6th year or 4th year, they were doing surgery. I have one of my students, he was in the 4th year when he joined us and graduated just last year. You know how many years delayed. This gentleman, he's a pioneer in the CPR. He was a pioneer. He was doing CPR in the same time for 3 patients and giving orders to the nursing around him. He was actually expert, maybe though more than graduate from American Heart Association. Honestly, they did a lot. When you find such things around you, you will not be able to leave those innocent people alone and not working and try to help them. And this is part of our duty.
It's amazing. I mean, 22 people for, 500,000 is just astronomically high. And these, you keep talking about them as, doctors. How many of these are actually surgeons doing the trauma surgery?
Not the trauma surgery. We were general surgeon, only 3. General surgeon and 2 orthopedic surgeons, 1 urologist, and 1 resident vascular surgery. He was going back and forth. We were not staying in the Aleppo. We were maybe working 15 days, 20 days continuously, and then left to see our family outside in Turkey. I will never forget a day when one of my friends is a surgeon working with us. We've asked me about family, and his family were in Aleppo at that day. And so many barrel bombs were around us and hitting the hospital. And I was doing with him a surgery in a corridor. There is no place because the whole operating theater, which is only 3, when you are talking whole, only 3 operating theater in that hospital were full with the patient. And there is a patient with abdominal trauma. And me and him started the surgery in the corridor. And he was feeling noisy. And what happened? What's happened, my friend? He said, I'm afraid there is something happened to my family around the hospital. So I've told him, we are going to lose a surgeon. You have to leave now in such a chaos situation. But we have to. He's now concerned about his family, concerned about maybe one of the barrel bombs kill member of his family. So I've told him, okay, dear, you can go and double check and see your family that they are safe. And if you're able to come back, okay, otherwise you can stay at home, just take care of your family. So for that reason, this is maybe the main reason of taking our families away, just at least that be able to concentrate, to focus when you are doing such type of surgery. This is the situation at that time. Of course, there is a lot of other problems such as the electricity, the equipment, the medications, and these all horrible things which wasn't available in enough, or not enough, maybe half, or maybe less than half of the enough amount for those people.
Gosh, I can't imagine how stressful that must have been.
Yeah.
You speak about doing things like surgery in a corridor and in places that aren't fit for operating normally. But one thing we haven't touched on is the anesthetic side of it. Do you have anesthetic colleagues, or how are you going about that?
Anesthesiologist, only one, working in 3 hospitals or 4 hospitals maybe. We rely on anesthesia technician only. We rely on anesthesia technician. By the way, our nightmares were the ICU. When you are sending a patient to the ICU, who will be able to follow up? There is no intensivist. We have only some technician intensivists who are maybe one following 3 or 4 or 5 patients. And the total number of ICU beds is very few in that situation. If you are able to send the patient to another hospital outside of the country or outside of this area, it will be fine. Otherwise, we'll keep the patient in the hospital. In that time, we started maybe the first trial for telemedicine. We inserted cameras, IP cameras, and connected to a group of volunteers around the world. One of them is now in the United States, Dr. Maghrabiya, and Dr. Anas Maghrabiya, he did a paper. He wrote a paper about telemedicine, tele-ICU in Aleppo. And honestly, he survived many of our patients. I visited him one day in United States, and he was talking about the patient and know about the patient much better than me. He was my patient, but he knows about the patient much better than me, honestly. And many of those doctors help us a lot through this telemedicine. And it was a good idea for us and help us a lot. And by the way, we are planning now for telemedicine and tele ICU maybe in COVID problem.
It's so crazy. I mean, some of the things that you brought up have been fairly hospital-wide. Example, barricading the hospitals, being underground. You have talked about doing surgery in the hallway. What are some other major complications that you ran into while you're trying to provide surgical care in a war zone? What are some of the other complications that you had to mitigate, I guess?
One of the issues is working maybe as administration. You have to be accountant. You have to be a hospital manager to deal with maybe diesel problem, with any maintenance, even if you are a doctor, even if you are a surgeon, even if you are a busy, you don't have time, but there is no people to run all of this. You have to arrange for referral for those patients. Maybe you'd like to refer someone to another hospital. We made some sort of network and connect this network around us. And even the internet, it wasn't easy to have internet at that time. We have satellite internet and try to communicate with each other in a hospital. We have some sort of this talkie-walkie network, just try to communicate with each other. For example, if I have a patient in maybe an orthopedic injury, and the orthopedic surgeon is not in my hospital, is somewhere else in another hospital. So I have to communicate and try to find if this surgeon, orthopedic surgeon, have enough time to receive another patient, just to mitigate and try to decrease the crowding of any of our hospital and maybe the queuing of those surgeons who are working and doing in another hospital. So even maybe sometimes they call me on the talkie-walkie, there is a vascular patient somewhere else. One of the important issue is training surgeons in terms of surgeons, not necessarily general, maybe orthopedic, maybe urology, to do everything, to do all types of trauma. I'm a general surgeon. My friend, he was orthopedic. Another one, he was urology. This is the main core specialty available, let me say. So those 3 specialties, they can do everything. Urologist can cut the colon, can open the chest, can stitch the heart. He can do vascular surgery. And by the way, this gentleman up till now is in Idlib right now in this moment and doing the same. Many times he suture a heart, he stitch maybe a lung, open the chest, and doing some vascular surgery. And again, it's the same for me. For example, I did many cesarean section, and maybe I did a lot of vascular surgeon and cardiac surgeon, so surgery, sorry. And one of them, by the way, it is published in a paper, maybe I send you a copy about it, about 12 cases of heart surgery, heart injury. When I said this one day in a conference in the United States about cardiac surgery, I was laughing when they said that they found 2 or 3 cases in 5 years. I've told them that we saw 5 cases in one day. This is not in years, in days. So afterward, maybe in 2014 and 15, I've been to work only as a vascular surgeon, only as a thoracic surgeon. They used to, okay, now you have to stay at only vascular surgeon. Another guy will do general surgery. No need to exhaust yourself in abdominal surgery or any other surgery. This is, and in the same time, it was honestly the visit of one of the heroes. Honestly, the hero, he was Dr. David Note. David Note is a trauma and war surgeon. He visit us and stay in Aleppo for 3 weeks in the first visit. The second visit again 3 weeks. And we learned a lot from this gentleman, especially about trauma surgery. Before that time, when I had a patient with a chest trauma, for example, the criteria, if you have 1,500 blood coming from the chest tube, you have to open this patient and do thoracotomy. In that time, I used to keep him maybe 2,000, 3,000, just give him the blood because I don't have the ability to do, or maybe I don't dare how to open a patient with open chest, and I'm not a thoracic surgeon. Afterward, when David came and taught us how to deal with such patient, we did a lot for such patient, and many of them survived, fortunately, afterward. So maybe the biggest message in such chaos situation, the biggest advice, we have to learn, we have to train those staff to do everything. Like now in COVID-19, you see non-intensivists and maybe veterinarian doctors who are doing intensivist and dealing with a patient in the intensive care unit. This is, I think now the whole world see just a little tiny part of what's happened in Syria in such context.
It's great to hear that despite everything, you guys were still working to build on your skills and had people like David not coming over to support you and your team out in Aleppo. Obviously, he was there for 3 periods at a time, but in between all of this, how did you guys continue to train and also train others, such as the medical students you mentioned earlier?
Many of our friends, one of them is David, by the way. I will send you also a link. It's on the BBC, you can see it. When David, on real time, doing surgery from UK in Aleppo. It is funny when you have, I think, you know, if you have Skype and you have this stick, selfie stick, but selfie stick, it was used for telesurgery. Just put this selfie stick, and the doctor, he was doing maxillofacial reconstruction. And there is general surgeon, maxillofacial surgeon, and David on the other side in his office in London. And he was just telling the surgeon, take this flap, take this muscle, do this like this, take this side, stitch here. And he was teaching those doctors how to do this surgery. This is the same in different contexts. I used to call one of my friends, Dr. Ahmed Tarakji in United States, is a thoracic surgeon. And I had a patient with thoracic surgeon. How can I do? Okay, Ahmed, I have this patient. He has this problem and this problem. He said, okay, can you send me some photos? Okay, I send him some photos or videos. Oh, Mahmoud, do this and this and this. It will be fine for you. It will be easier for you if you did this. One day, by the way, there is some what's called in the damage control surgery. You are just packing a liver, for example, if there is a bleeding, and keep the patient for 24 hours in the ICU and take him back and second look and see what's happened. Could be applicable in the abdomen, but is it applicable in the chest? Honestly, I didn't know at that time. And one of my colleagues, he opened a chest and there is a bleeding. He put a pack to the chest and he said, okay, Mahmoud, I was going to send you this patient to the ICU because no bed in our hospital. And you have to follow him and again, reoperate on this patient in 24 hours. I said, oh God, how you are baking the chest? I cannot imagine that you are baking the lung. How the patient will breathe? I contact Ahmed. Oh, Ahmed, we did this. Is it real? Is it correct? I don't know. He said, Ahmed, how you did it? I said, no, I don't know. On the other day, I open the chest and take the pack out and wash the chest, again ventilate the patient, and patient is okay, and discharge home. It was very great for us. Maybe I don't get the consent from the patient how to do it, but fortunately he survived. Honestly, I do believe that this is maybe part of unfortunate when we were using, this is very important issue in such context, is to document what's happened. We don't have any time for documenting all things which happen. Always war or conflict like this maybe change the textbook, maybe change the guidelines, maybe change the rules of surgery. This happened, I think, in World War II. And in Syrian war, maybe many of the guidelines could be changed. Small example, many patients will receive them with injury to the left colon. And if there is injury to the left colon, you have to do colostomy for this patient, because maybe not 100% for all patients. But actually, in reality, what we did, if you had a colostomy for a patient, it's a nightmare for him. There is no colostomy bag, no way to clean, no way to put these fancy things. They used to put just plastic bags on their tummy just for these tools to come out. So we thought that why we are not doing primary suturing for colostomy, for the injury in the colon, rather than doing colostomy. Let's try for sake of those patients. And we find many of those patients, unfortunately not fully documented, that we can do primary suturing without a protective colostomy for those patients, and they survived without a fistula, without a wound infection, without any problem, and which is much better for those patients rather than doing colostomy and going home with a colostomy, which is very difficult for them. Another example, one of our colleagues in Canada, he invented simple things which was very useful and now implemented in Syria, which is the vac. You know the vac dressing. It's very fancy and very nice, but it needs a small little machine, totally cost around $1,000, which could not be applicable in our context. This pioneer doctor, he invent, let me say, handmade vacuum. He put a bottle like Rodin vac and fix it to and measure the pressure which will be applied, and we use it, and the cost it was for each single patient around $50. So the big difference. So imagine that you are using this handmade vac, which is useful for thousands of patients, very simple, decrease the time of healing, decrease of time of staying in the hospital, decrease of time and the cost also, and immediately send the patient if you'd like to put any implant or anything or cover the skin. And it was very easy for this patient. This is part of things which is implemented in Syria.
That's great, actually. And I think the nice thing about that is it just goes to show that there's so much that other countries could be learning from your situation. And all of these technologies that are being created for the Syrian situation, I'm sure could be sent to so many other parts of the world, both high income and low and middle income, provide a cost-effective way to provide a vac dressing.
Sure, sure. The only missing things is the data. We try to have data as much as possible, but at that context, it was very difficult for us to document. We used to document by video only, and there is maybe hundreds and millions of these videos on the webs you can find about how those doctors are doing with our patients. But the
Hmm.
only missing things, unfortunately, is real document. I had, for example, a statistic for 200 patients, which we did in Aleppo City in a year, a vascular surgery only. And when I tried to find the blood group only, documentation for those patients, it's missed, unfortunately. When the doctors evacuate from Aleppo, for example, they enforced to burn all of these documents just for sake that not being in the wrong hands, and otherwise maybe some person will be, we don't know what will happen. So unfortunately we have some hard disk taking some of these photos, some of these videos out just to document what's happened.
You're trying to basically run an entire health network completely underground, right?
Yeah,
So not just underground, like both physically and figuratively. Of, you don't want them to see your name. You're using a fake name as a doctor. You're not letting your medical students see you. I mean, this is really dire circumstances where you're working, where everyone's life is at risk, not just the patient but also the
sure,
provider.
sure.
Um, and you're having to get creative with different technologies and how you do this with being in a resource poor setting, as well as in a war setting. So and you've talked a little bit about working with other outside international organizations to do some of the training, or for example the Skyping in or telemedicining in to help with the surgeries. What about some of the other international organizations? Were you able to work with anyone who was maybe able to donate some of these supplies? And what was your experience working with international organizations to provide that surgical care?
Well, we work with many international NGOs in different pieces of the world, either in UK, in France, in Belgium, in Spain, in United States, and we are still cooperate with them. Some of them do some of training, like MSF, for example, MSF Belgium and MSF France. They
Mhm.
did some training for our staff, but in general we rely on our diaspora's friends. The matter of language, it was one of the problem. Most of our colleagues inside our country are speaking Arabic, so it wasn't easy for them to deal with non-Arabic speakers. uh, for example, when I've been in United States, we had an emergency course somewhere, and I've met with one of the emergency physician in the United States. This was also very helpful, and we've established a team for emergency physicians. Most of them are pioneer around the world, from United States, from Singapore, from Vietnam, and they did many courses. And we start this course with those five emergency physician to our colleagues inside Syria. The major problem was language. When they used to do this course online, of course, it was planned to be a 1 year course for emergency physicians. They found it difficult and found a problem in communication. So this is one of the main obstacle for our colleagues. Only few of them are fluent in English and able to understand and speak in English fluently. So this is maybe the main problem. Therefore, our colleagues in diaspora or Arabic speakers in Gulf countries, for example, many NGOs, they did some courses, some training. And the last training, by the way, 2 weeks ago, we did 2 days for surgery day, all of them, which is the thanks for maybe for coronavirus. We're doing these online courses, and many people can join these courses online, even inside the country.
That's awesome. It sounds like a really great way to engage different people and also use the local network of other Arabic surrounding countries that may have a similar situation, and may have doctors that have practiced in Syria previously. One thing that I'd like to circle back to that you mentioned in your biography is that you worked previously with the Scholars at Risk program. Would you be able to just describe what that involved and also what it provides from an academic point of view?
I visit United States in 2014 for a month, and I can say each night in a state. So one of these nights, it was in Los Angeles, and there were a conference for American College of Surgery. Tyler, this name is very lovely for me, and I like it because the one who called me for Scholar at Risk, his name was Tyler, by the way.
That's
So
good.
after a month, I received an email from a guy who called Tyler. He was a medical student in I think in I don't know where, at Harvard, at Harvard, and he said, "Oh, doctor, there's a program called Scholar at Risk. If you like to join us, it will be fine, and I'm going to nominate for this program." I said, "I'd like to read about it and ask my friends before doing this." I was in Aleppo that day, and okay, they start this process and send me that it will be good chance for you. I said, why? They said, okay, this will be helpful for at least sending your message and distributing your message around the world, especially in the US, and it will be helpful for you. And also you can do some research and train for some academic courses over there. Uh, okay, agree, doing all of this paper and accepted and traveled to US with my family, and it was a very lovely year for me and for my family, joining such amazing team at I work with HHI, Harvard Humanitarian Initiative, and I learned a lot for them, and up till now we are doing some research with this lovely staff. I'm still in communication with them. I did maybe every week there is one or two presentation talking about Syria in different areas in New York, in Princeton, in I don't know, maybe I cannot remember all of this university I walk around. In addition to doing some very great, amazing course at Harvard Macy Institute for education, for doing research, for how to learn about courses, how to initiate a course, to a floppy course, all of these nice issues. And back to Syria, back to Turkey, sorry. Uh, Still working now. There is a paper. We're working a paper about education in health in such situation, health education in such conflict area, and we are doing some sort of comparison with our friend at Harvard in this issue. This maybe make more initiate for me and for my colleague to work a lot about paper, to work a lot about printing, about publishing, about sending document, and it will be helpful for documenting, maybe to cover a little about this gap about documentation.
Yeah, I mean, documentation, as you're saying, just must have been so hard. You're burning records, like, because you're trying to provide privacy. You don't know who the doctor is because you're using, code names. So I think that's actually a perfect segue into, we'd love to talk a little bit about your study that was recently published in JAMA Surgery, which is, congratulations, that's so great. It really talked about the capacity of Syrian trauma hospitals. How in this setting did you manage to undertake such a study in the midst of burning records? And as you said, the data collection, how hard that was. How are you able to do that?
Well, I was working with an NGO as a research director. In addition to working in Aleppo, I was going back and forth and try to establish something related to research. There's three papers. The first one, it was about one of in JAMA, and I don't remember that. Sorry. So we started to collect data since 2013 with a couple of colleagues. One of them is in Canada right now, is a trauma surgeon, and one of them in France. And we started to collect these data, but only in a hospital, and try to find out as much as possible accurate documentation, and if you have these document anyway, and we collect data about 200,000 of a patient, trauma patients, what's happened for them, how many infection, how many, what is the rate of bleeding, what the rate of the fertility rate, what all of these issues. And the one actually who was the great help for it's from Yale University, Dr. Hani Muafi. He collect all of these together and uh, send it, and maybe he's the only one did his best just to make this paper published with some of his staff around him at Yale University. This is this is the first time, by the way, visiting Yale and meeting with Hani. And I used to advise my friends afterward, please try to document as you can. Publishing is not a luxury. Publishing and documenting and sending your voice to the world is, your voice will be much stronger if you are going to publish. Is much stronger to see that you are documenting what you are doing uh, in your great job. Uh, Fortunately, many of my friends now interested and try to work on the papers. The second one published also by support one of my friend in HHI. It was about cardiac surgery, as I told you, a case series. And there is another paper also, hopefully in the way to be printed in Lancet, and maybe another one at JAMA Surgery. Hopefully that it will be pass.
That's very impressive that you're doing all of this thing. And I really have to say that I like your ethos of continuing to do research and making that mandatory as part of your job as a clinician, despite all the difficulties that are going on around you. Because oftentimes that's the thing that you would think would take a backseat. You, at some point in your career, you were the director of research for a large NGO, so the Union of Medical Care and Relief Organizations. What did this role involve, and what was your challenge in this role with running the research capacity?
Well, for the guys inside the country, they don't think that research, it's time for research, it's time for documenting, it's time for doing all of this. They find that I'm maybe speaking from out of the reality, but I'm trying to push for this regard. After finishing my work, I finished, by the way, my work on the NGOs as a research, but I start working with Health Directorate for something maybe more important than research even. But it's going in the same level, on the same, let me parallel to the research work. Currently in my country, there is, as I said, there is no real documentation and there is no unified documentation. This is what we are working on now. We establish what's called the Health Information System Unit inside the country. It is working with Health Directorate as a governance body. We try to support the governance body, the policymaker now in liberated area, how to make much better decisions. So now we started this on a very important and nice platform, which is DHIS2, and we start entering data, maybe not case by case, maybe aggregated data, and have very nice and very important information. So this is parallel to the research work, but now we are developing this process and try to find out, let me say, if you ask any NGO or any doctor in Syria, what is the mortality rate for hypertension, for example? Nobody will answer such question. What is the under 5 years old mortality in our country? Nobody knows. This is what we are trying. This is very basic issues. We are trying to building this very basic issue in our country. Hopefully, we started 2018, at the mid of 2018, training our staff and established this unit inside Syria. And by the beginning of 2019, we started data collection. By the end of the 2019, we had the first annual report in Syria. Actually, the first real annual report in Syria. Even in all of Syria, even in regime area, there is no such report, there is no such document and accurate data as much as possible. Now
Yeah, I
we
mean, I
are
think that's just
modifying
such an
these
important
forms,
thing. Like you're
try to
saying, you
have more
put it out there
accurate
so that people know
data
about the
depending
issues,
on
and then also so
ICD-10
that there can
forms,
be a
ICD-10
building up
codes,
of the
but we
infrastructure and different
abbreviate.
things
We
based
try
on
to
the research that you're
shortlist
providing,
these
right? As you
ICD-10
said, if
from
you don't tell anyone about
14,000,
it,
for
then
example,
nothing can
to
be done,
only
right?
250
So
main
perhaps,
diagnoses.
like
But
you
follow
mentioned that
it
you
and
worked
stuck
with
to the
researchers at Yale. I
ICD-10
remember when you
to
came
keep close
to
to
speak
it
to us
and
at
to have
Yale 3, 4
more
years ago now,
diagnosis
you were talking about
accurate
these
with
collaborations and
codes.
stuff. And so
And
what tips would
hopefully
you give
this
to
will open the
researchers
door
in these
for
low resource
real
settings to work
documentation
with
and
partnerships in high
the
income
research
countries,
in the
colleagues,
future.
and how to
So
publish and
this is
conduct those
very
results?
essential steps. Hopefully that it will be succeed and it will be useful for the future of our country and to build our country. Yeah. One of the issue is language barrier and opening to the outside, opening to the outside, see what's happening in the outside. Now, many of my colleagues are interested in these issues. There is many papers now published from other colleagues. One of them is a neurosurgeon, is working currently in Bab el Hawa Hospital at the border, and he published maybe 2 or 3 papers about challenges in neurosurgery when he was in besieged homes, for example. Another friend, he was working with us also, and now he is completing his education training also in neurosurgery. He was working in Aleppo hospitals. So many of our friends now opening and try to opening doors for outside to see what's happening and what is the importance of publishing. Maybe there is our colleagues in United States, they did 2 courses, by the way, online courses. The one is how to write a paper, and the other how to do a research and what type of research. I've been in one of my friend in at Mayo Clinic. He's a Syrian, and he did a very nice course also for research, type of research, how to do research, what the meaning of research, what's the difference between types of this research. This term, it wasn't applicable before in Syria, and now there is these open minds who are willing to do something useful and willing to document, to record, to do some sort of these papers. Hopefully that we'll have more and more soon.
That's great to hear that you've got such productive collaboration with all of these colleagues and that you're actually managing to get quite a lot as well as sharing your results with others.
Yeah.
Thank you so much for just discussing all the challenges of conducting research and how you've managed to be so successful with the number of papers and the number of things you've brought out of your situation. Just moving on to the next section now, just a few more questions. I can imagine when you first started your career as a surgeon, you probably couldn't imagine that this is how your career would have turned out. Now, having looked back, what advice would you have given to yourself now at the beginning of your career, having seen all the things that you have seen?
Well, maybe if I said that, what if I am back 10 years ago, what I have to do? Honestly, by the way, when I was working in Aleppo University in 2009, I start maybe the first research because numbers and research may be part of red blood cells are quite white blood cells is running in my blood. So I started the first research talking about the checklist, surgery checklist. This is a little paper before going to any surgery, how to do this checklist for all of your patient and what is the importance of this checklist for saving lives and not missing any problem for our patient. And my advice for all of my friends to work from the beginning to understand the importance of research, the importance of research and documentation. This is very, very, very essential. Should be going together with your training. And this is what we are learning now well, we establish, as you know, SPOMS, Syrian Board of Medical Specialty, which is now running and educating and training many of our students. And we enforce and try now, no way to be graduated from SPOMS if you don't have at least minimum small one paper published or research published for you. Even auditing, it doesn't matter, but at least you have to work on the research to understand the importance of research in your work, in your life, in your practice. To go for evidence, go for evidence-based surgery, evidence-based medicine when you are practicing. It's not just practicing as far as, okay, I graduated, I can do everything, I'm now can do my surgery very easy, but you have to know what's happening. You have to know what's going on. The medicine and surgery is changed, maybe daily basis, maybe yearly basis, it doesn't matter, but we have to know as doctors what's happening on the ground. Wasn't the reality before in Syria, and now a lot, and maybe all of our friends and colleagues, they are doing their best to be updated in all of these update in their specialty. Maybe there is a barrier of having resource, which is very important. If I said, what's your message for those people outside Syria? Okay, support those people with resources. Give them access. And this is, by the way, we had access for UpToDate, for example. This is very fancy, a nice website. And we have some access to some of the library, for example, in BMJ, British Medical Journal, they gave us access, open access and free with a limited number, and send it and distribute it for our colleagues. Resources is the most important issue, can be supplied and send it to those guys who are working on the front lines, who are maybe risking their lives to serving others. The issue of language could be sorted out. It's not a big deal. They can learn, and they have the willing to learn.
And that's great that you're sharing this with the next generation. You've found it to be so important, and now you're training up people to think of research and to publish the results and to do this critical thinking. I think that's what I've learned through the research that I've done, is how to look at a problem and critically analyze it and think, what are the weak points, or like what's creating this situation, and what factors do I need to look into to be able to better understand the problem, right? That's what research is you create this hypothesis based on a problem that you're seeing or you think might be there, so that you can then find data to back that up so that you can actually do something about it. So I think that's fantastic. So I think you're being a great mentor and a great, influencer on those people who are coming underneath you. But we'd like to just have you tell us a little bit about an important mentor that you've had in your life and how they influenced you to be where you're at today.
You mean on the social level?
Sure, on a social level, on a medical level, just a mentor that's been really important to you in helping to get you where you are today.
Well, if I ask myself a little question, what if I did not contribute in this revolution? What if I'm still working in Aleppo University as a scholar in the other side, in regime area? I think I will lose a lot. Honestly, a lot of things has been changed in my life, in my career, as a doctor, as a surgeon, as a researcher even. I haven't dreamed that I could be a researcher. I haven't dreamed that I will be able one day to publish a paper in such journal like JAMA, for example. There's a paper, by the way, which is submitted yesterday. Also, I've been one of the co-authors with them, happy to, about health education. Maybe it was part of a dream, which I haven't expect to be happen if I'd not be like this and working. And maybe this is the God mercy, which is give it to me just as a part of the price, maybe send it to from my God. And really thanks for this fortune for me, for this luck. I do believe that it was very, very, very important and changed all of my life, and even the life of my family, by the way, even the life of my kids, all of their life changed. Feeling free, feeling freedom, looking for freedom. Now, if you ask my son now will be in the university next year. So if you ask him, what do you know about freedom? What do you know about democracy? What do you know about research? What do you know about building yourself, building your career? Open your mind. You will find him very open and very great little boy. You will be a man for the next future, for the next generation. I do believe that it was a great chance for me, and thanking my God for giving me this opportunity to build my family, to build myself, and to help my people as much as possible. And I will keep going, inshallah, until the last day of my life, the last breeze in my chest, till helping, till doing my best for my people.
Wow, those are some really profound and inspirational words there. You say luck, but I'm sure there's a lot of hard work that's gone on to get you where you are today, and a lot of dedication to your people and to your practice. We'd like to wrap up our interview now with just asking 5 questions, and these questions are dedicated to the billion people worldwide who lack access to safe and affordable surgery. The first question we have is, what is the most recent book you've read?
I'm reading stories out of this about medicine, because my wife, she is a writer, and she published recently a group of these stories. One of these stories, by the way, it's converted to a film at Harvard University, by the way, and it's around the world. It's 7 minutes short story and 7 minute film. I'm reading out of surgery, maybe out of my career sometimes, but now, unfortunately, the COVID-19 took everything, took all of our times, or all of reading, and all of the broadcasts is about COVID-19 and reading what this little virus what did in our life. But usually I used to read outside of the surgery, reading other books other than maybe in Arabic literatures, in stories, in novels, something like that, rather than only reading medicine and surgery, which is maybe getting bored of it.
It's definitely hard. I mean, you're balancing a lot of things, and reading is something we do every day. So our next question is, what's something that not very many people know about you, or a unique talent that you perhaps have?
Well, I think people know everything about me because I'm very talkative and so many people meet me. I don't know. I don't know. I have no answer for such question, unfortunately. There is nothing hidden in my life. Everybody know everything. You just Google it.
For another question, what was your favorite toy growing up and why?
No, I'm just going to the maybe going for Twitter and Facebook.
So our fourth question is maybe a little bit interesting for you. It's how would you spend $1 million?
$1 million at the same time?
Yeah, you got $1 million. What are you gonna do with it?
It's out of my dreams. It's out of my dreams. I cannot imagine, honestly. In Syria, there is a small project, can be great, helpful, and build a lot for small project. I used to say, if you have $1 million, spend it on small projects. It can build a lot in such a small, beautiful area in my country. I think such a small project for individuals, many people can help a lot, for maybe thousands and thousands of family who are now depending more maybe on support from donors, from I don't like people to stay and waiting for someone to give them donation. We used to say, one of my friends, he's working in an NGO inside Syria, and he's very nice guy. He used to say, if you like to start a project inside the country, don't give a people a pack, maybe a box with food or something already prepared. He used to give the people seeds to implant. Go and implant in your land. We will never give you anything else. It's enough to build yourself, to start by yourself. This is very important to people in my country. People now living in camps, maybe some people even do not found a camp, do not found this is, they consider that when they said stay at home, And this slogan, which is now all over the world, stay at home. One person said, okay, if I'll have a home, I will stay at home. I have only tent or maybe living under the tree. Which home I have to stay? So I think that if anybody have a money, have to support those and give them opportunity to build themselves rather than keeping them rely on donation coming from there and there. They will be like a slave in the future, feeling that, okay, we're waiting someone to feed us, to give us this piece of bread to be able to eat and give it to our kids. This is the most important, I think. If you like to spend $1 million, I can spend it like this easily.
I think that's a really good way to spend it. That sounds like a great piece of advice there. And we have our final question, which is for yourself now, which is about what is the best piece of advice that you've ever received?
The best advice, feel free. Do not dare from anything if you are on the right side. Do not dare from your word, and do not keep the word in your heart. You have to say it. You have to dare to do everything. For that reason, sometimes they used to call me the black boy, the black guy, who are saying something must not be said. But I used to say, no, if you are right, say it. If you are sure that you are right, say it. And if you feel you did something wrong, please apologize. And you have to know, and this is one of the biggest message was said to me one day, if you felt that you did something wrong, apologize. Feel wrong piece of apologize. Don't try to give yourself excuse. No, you have to say, I'm sorry. I'm sorry. I did this is wrong. I should not say this. I have to say this rather than this. Be strong enough to say, I'm sorry, and be strong enough to say, I am right. And this is the right things to do. This is the most important message in my life.
Thank you so much. Those are very powerful words to just think about and to really go with what you feel like is right and to stand up for what's right. And I think that you're a really good example of that, you know, working in an area where a war zone and risking your life every day to provide medical care for people around the world who really need it, and or rather provide medical care in Syria, but then to disseminate that information around the world is really inspiring. So we're very grateful that you were on the show with us today and hope to continue to see more of your research out there and continue to learn from you.
Thank you so much. Thank you for your interviewing. I think we spent more than 1 hour and a half. I did not feel about this. Thank you so much, honestly, for your time. Thank you for hosting me. I'm really honored to be with you guys. Thank you so much indeed.
No, thank you for sharing so much of your time. It's been fantastic hearing about, I think the theme that came through for me quite a lot through a lot of what you said was knowledge sharing, whether that's through publishing, through teaching, through documentation, or through sharing resources. So I'm really looking forward to sharing what you've had to say with everyone listening to the podcast.
Thank you so much. Thank you so much indeed. Thank you so much.
We hope you enjoyed this episode of Global Scalpels. If you're interested in learning more about this topic or the speaker, visit us on the web at globalscalpels.com or any of our social media platforms. Please subscribe to our podcast on Apple Podcasts, Spotify, Google Play, YouTube, and Stitcher to hear more great content on a wide range of topics within global surgery.
If you or someone you know is doing something in global surgery you feel should be highlighted in Global Scalpels, we would love to hear from you. Thank you again for joining us today and hope to see you on our next episode.